Hello. So my presentation looks at a health policy to expand access to care outside the regular working hours and its effect on emergency department visits across multiple provinces. Let's check it out. In the early 2000s, many Canadians faced difficulty accessing primary care services, especially for services that required immediate attention, as well as services provided outside the regular working hours. Instead, many Canadians visited the emergency department, with almost 2 in 5 ED visits being reported to be avoidable had primary care been more accessible. To that end, the federal government funneled millions of dollars into primary care reform with 5 major objectives. The one we'll focus on is expanding all-day, everyday access to essential services. Given that primary care is delivered by each provincial and territorial government, each government had a different response to this objective and a different priority to it, and we'll see differences in how they expanded access. Each of the 10 provinces introduced some form of an after-hours premium or an incentive for physicians who provided services outside their regular working hours. However, these premiums differed in what they actually incentivized. Alberta's after-hours time premium, for example, was only available for services provided in hospital, while Manitoba's premium was only available for urgent and emergent services. I'll focus on Ontario's after-hours premium, which is available for physicians who expand clinic hours for their patients. Ontario's after-hours premium is available to physicians who provide services in the clinic to patients enrolled to their group. It can be billed on services provided during evenings, weekends, and holidays, but only to those basic services that are incentivized. Since its introduction in 2003, it's gone several changes, including expansions in the set of services that are incentivized, as well as increases in the value of the services. Previous evidence examining the effect of Ontario's after-hours premium found that the introduction and then the later increases in the value of the premium were associated with slight reductions in less urgent ED visits. This falls somewhere in line with the previous evidence, which shows that the effect of improving access to after-hours primary care on ED visits was dependent on the intervention and the healthcare setting, but could be associated with slight reductions in ED utilization. So this study seeks to examine whether the latest increase in Ontario's after-hours premium in 2011 was associated with a reduction in ED visits, both within Ontario, as well as compared to other control provinces where no increase in their after-hours premiums occurred. Data from this study comes from 2 sources, from CCHS as well as from NACRS, which were recently linked together. Due to limited coverage in NACRS, we restrict to 5 provinces, Ontario plus 4 control provinces, as well as restrict to residents within 10 kilometers of the nearest ED. Respondents are taken from 7 cycles of data, from 2010 to 2016, and we use demographic, socioeconomic, and health variables from the CCHS, and link that to ED visit information for the same year they were surveyed from NACRS. For the first part of this study, the within Ontario part, we use multivariable negative binomial regression models to assess the effect of increasing the value of the premium on the number of ED visits per year. ED visits were stratified by urgency based on Canadian Triage and Acuity Scale score, as well as by timing, separating regular hours versus after-hours visits. For the second part of this study, we use a difference in differences analysis to evaluate whether Ontario's after-hours premium had an effect on ED visits within Ontario relative to control provinces. This analysis relies on 3 differences. First, we take the difference in ED visits before and after the increase in the value of the premium in Ontario. Secondly, we'll take that same difference among control provinces. And finally, we take the difference in these 2 differences to assess the effect of the increase in the value of the premium on ED visits in Ontario relative to the control provinces. As the Canadian Community Health Survey is conducted using a multi-stage survey design, all analyses here are conducted using survey weights and cluster bootstrap standard errors. Analyses are also conducted using multivariable regression models, adjusting for a set of demographic, socioeconomic, and health-related variables. In the Within Ontario analyses, we find that the increase in the value of the after-hours premium from 20% to 30% was associated with a 15% reduction in less urgent ED visits, mainly through a reduction in visits made during after-hours. Although the increase in the after-hours premium wasn't associated with total ED visits, there was evidence of an increase in very urgent ED visits, both during any timing as well as mainly through those visits made during after hours. When compared to other provinces, the effect of the after hours premium on less urgent ED visits is completely erased. Instead, while the after hours premium is not associated with total ED visits, it is associated with reductions in very urgent and urgent ED visits compared to other control provinces. We can take a look back at that figure to examine why this might occur. Despite the fact that the rate of ED visits is lower during both time periods in Ontario compared to the control provinces, the reduction in ED visits after increasing the premium is greater among the control provinces than compared to Ontario. In summary, our results agreed with previous analyses. The increase in Ontario's after-hours premium from 20 to 30% was associated with reductions in less urgent ED visits. Subgroup analyses also demonstrated slightly larger effects among expected subgroup populations, including those with a chronic condition, those with a physician, and those who had full-time employment. However, all effects disappeared after we compared to control provinces, and the after-hours premium was not associated with a change in total ED utilization or less urgent ED utilization. These analyses come with the limitations inherent to using both cross-sectional and observational data, as well as additional limitations due to linking the two data sets together. Firstly, both these datasets lack information on physician characteristics. In Ontario, only set physicians may bill the after-hours premium, and while we treated it as all patients being exposed, this may have biased the effect towards the null. Secondly, we can't capture what happened before the ED visit. Although NACRS gives us the timing and the urgency of the visit, there's no information on whether a patient tried to seek care before in an alternate setting, or whether they were referred to the ED visit. Finally, it's impossible to completely isolate the effect of the after-hours premium, and changes such as that reduction in very urgent and urgent ED visits in Ontario relative to control provinces could potentially be due to other policies or upcoding of triage codes. This study explores the effect of Ontario's after-hours premium on ED visits. However, after-hours premiums across the country differ vastly. Future research could be used to compare the effectiveness of different models of after-hours premiums and which might be the most effective at limiting ED visits. Additionally, our subgroup results revealed differences by income. The effect was slightly larger among those in the lowest income category compared to those in the highest, and so future research might be used to evaluate potential inequities that exist in policy change. The increase in Ontario's after-hours premium was likely not responsible for a reduction in less urgent ED visits, at least not causally. And so when introducing or increasing the value of an after-hours premium, those intended and potential benefits of the initiative should be weighed against their financial costs and other negative consequences that may occur. Thank you. I'd like to thank my supervisors as well as my funding sources for helping along with this research. Thank you for listening.